On behalf of researchers, sorry about that. On behalf of Research, Training and Innovation Center in Kenyatta National Hospital, to welcome you to today's session. Today's session is a collaboration between KNH and University of Nairobi, and therefore we have great speakers lined up for each one of us. Thank you for joining, but if you can tag someone to also join us, it would be a great thing, and we can learn together. For the speakers, I take this opportunity in advance to appreciate each one of them, each one of you, even for accepting to speak to us today. I request that we start with a word of prayer from any volunteer, and then we move on. Any volunteer, kindly feel free to pray with us.
Let's pray. Our dear Heavenly Father, in the mighty name of Jesus, we are before your presence this afternoon. We count it a miracle, Lord, to be alive. We give thanks even for the honor and privilege of being in this webinar. We invite your presence that God, you take us through and help all the presenters, Lord, to be able to communicate in the very best way possible, to even disseminate the knowledge they have to all the delegates. We give glory and honor to your holy name. In Jesus' holy and mighty name we pray, believing. Amen.
Amen. Thank you so much, Dr. Grace Wanjiko. Now we are moving to the first presenter, Divina. As I introduce you, kindly share your presentation. So Divina Kemunto Nyarera has masters in nephrology nursing, and she's a nurse manager with over 20 years experience in renal nursing. She's a member of Kenya Nephrology Nurses Association, African Nephrology Nurses Association, Kenya Renal Association. And we are privileged to have you, Nyarera, if you can take the floor. Thank you very much.
Good afternoon to you, colleagues. Can you hear me? You can
yes,
hear
we
me?
Can. Would you like to put your presentation on full screen?
I have. From my side, I don't know whether you're seeing. So this afternoon, I really want to thank this Kenyatta National Hospital Research and Training for this opportunity to interact with colleagues from Kenya and Africa at large. And from this desk, we are actually talking about nephrology. And nephrology, we will look at different aspects in the presentations that we have. I've been told I only have 10 minutes and 10 minutes to tackle a very big topic. So we are talking about patients with end-stage, CKD and end-stage kidney disease. And we want to appreciate that the incidence of chronic kidney disease right now in the latest researches that have been published, like one in 2022, we got information that 850 million people have CKD globally. And out of these, 43.1% are in end-stage kidney disease requiring renal replacement therapy. And in sub-Saharan Africa, the prevalence of CKD is between 6 to 16%, as it was reported by Sarala Niger and et al. That is 2017. And in Kenya, 10% of our population are also said to be in CKD, and we have quite a number of them who are in end-stage kidney disease, and they are receiving some form of renal replacement therapy. So on background, end-stage kidney disease is reported to be a major contributor of morbidity and mortality among the non-communicable diseases globally. And we have two types of renal replacement therapies, that is dialysis, where we have hemodialysis and peritoneal dialysis. And kidney transplantation is another modality. We also have patients at the ICU acute setup where they receive CRLT. So kidney transplantation is believed to be the best renal replacement therapy for these patients, and it is reported to improve the overall quality of life of patients. Studies have also gone further to talk about the types of kidney transplantation. You can have deceased and living donor. And living donor transplants have been reported to have a better graft survival, both graft and patient outcomes in terms of the researches that have been done. So then talking about living kidney donors, it is then important that we understand what is the quality of life of these donors after they have donated. So after they have given their kidneys, how do they go about their life? What becomes of them after? So WHO defines quality of life as the way an individual perceives his or her own position in relation to their goals and expectations. So quality of life defines how we make choices in terms of economic independence, guarantee for employment, career planning and development and social relationships that we have. This is what is defining who we are, and this is also defining our quality of life. So then we had a study, and the problem statement of this was that the global increasing prevalence of end-stage kidney disease has an increased demand for kidney donors. And we have also rightly, from the researches, the previous slides, we have seen that living kidney donors have a better quality of life and a better graft survival. And information about this quality of life of the donors, the living donors in Kenya, is scarce. We do not have a lot of information on what happens with our donors once they leave our stations after they have donated. So lack of adequate information on quality of life of existing donors in Kenya makes it difficult for us to make right information or to give right information to those who aspire to be future donors. And to understand the quality of life of these kidney donors, then it was important why this study had to be done. So in terms of justification for this study, living kidney donors are actually individuals who are healthy and willing to donate. And therefore, their quality of life should be of particular interest to us as care providers. And the prospective donors have also a legitimate right to know what is happening with the existing donors. And therefore, it is important for us to have a lot of data and information on where they can go and get information for them to help them make an informed choice whether to be donors or not. So these are the quality of life data data that we were looking to get were about their life mentally, psychologically, socioeconomically, how do they interact in the community, and what happens after they leave us. So the significance of this study is to help us develop policy and also to improve the criteria of selection of donors and talking about their outcomes, and also it's going to add to our knowledge. The research questions that we aspired to answer was, what is the relationship between socio-demographic characteristics and quality of life of kidney donors at Kenyatta National Hospital? What is the relationship between socioeconomic factors and quality of living kidney donors at Kenyatta Hospital? And what are the components? So the components here, we were looking at psychological factors and health functioning factors, which are the two domains of quality of life as at SN 36 protocol. So the broad objective was to assess quality of life of living kidney donors after kidney donation at Kenyatta National Hospital, with specific objectives to determine the relationship between socio-demographic characteristics and the quality of life, to determine the relationship between socio-economic factors and the quality of life, and to evaluate the components of quality of life of these donors that have donated at Kenyatta National Hospital. So the conceptual framework, we employed a modified health-related quality of life model of Firenze et al. 2005, and came up with this, the independent variables, as you can see. and the dependent variables with a modifier variable, which was a kidney donor follow-up. So the research design was a descriptive cross-sectional research design, and the area of study is Kenyatta National Hospital, located in Nairobi County, with a targeted population of donors, the ones who donated between January 2010 to July 2017. The sample size, we did a convenient sampling method, which was used to achieve the sample size. And the sample size determined through the Daniel 1999 formula for finite population correlation that was used to determine the size or the number of participants to participate in this study. And this is the formula. And after calculation, we got we were expecting to have a minimum sample size of 105 respondents to participate in this study. So independent variable was socio-demographic characteristics, socio-economic, psychological, and health functioning factors, with a dependent variable of kidney donor quality of life, which will be measured by psychological factors and the physical health that they present with. And the inclusion criteria, we only included anyone who participated in kidney donation for transplantation between January 2010 to December 2017, with an exclusion criteria of anybody who could have donated within this period but did not give a consent, and also the ones who donated outside this period. So we used a semi-structured self-administered questionnaire, which was done either interview or the self-administered. And the pre-testing, yes?
Just a quick one. So the slides are not moving for the participants. Is it possible that you're using the screen that you didn't share? Yeah, now it has moved. Thank you very much. Kindly continue.
I will request that. I think my computer has a problem. When I go to full screen, it does not move. So where was the slide?
Just start where you are and proceed.
Okay. I hope it will be able to move. So I was saying the pre-testing was done in Moi Teaching and Referral Hospital in Uasin Gishu County. So the data collection process was followed, and that data management was also done. Data analysis and presentation, we used SPSS 25.0, and descriptive statistics such as frequencies, percentages, mean and standard deviations were also used to assess the characteristics of the study variables. And the Pearson correlation model and chi-square was also applied to analyze the relationship between independent and dependent variables. And a regression model was also used to measure the relationship between independent and dependent variables. We also sought ethical approval from different bodies, that is Kenyatta National Hospital and University of Nairobi Research, and also Anacosti and KU Graduate School. So these were the results. The response rate was 94.3%, and we had more male respondents than female, with a small margin of percentage, which is also relevant to what other studies had said. And we had a mean age of 33%, indicating that we were actually drawing our donors from a young population. That is different from other studies from other countries where we have seen more senior people donating than it is in our country. The socio-demographic characteristics, Most of our respondents were actually had attained at least a college degree and above. And we had, from what the results showed, is that our respondents, from the time they donated up to the time of this study, we had a high number that increased for married population from what it was before the study. At this time of the study, we had a 79.8% increase in relationship, people moving from being single to getting married. And socially also, we looked at the BMI, and we had most of the people who donated were, at the time of donation, their BMI was near normal. On economic factors, majority of the people, that is 88.9% of the donors, did not change their occupation. That is, from the time they donate, what they were doing from before the donation and what they did after the donation was the same. So we had, it means then that the donation did not actually make them incapacitated to change their occupation. And there was a significant increase in full-time employment. At the time of donation, those who were not in permanent employment moved on to have permanent employment at a percentage of 59.4% rise. And there was an improvement in the total earnings, as shown in the reduction of the donors who earned 20,000 and below, and an increase to above 50,000, which means they were able to progress on after kidney donation. So in the components of quality of life, psychological factors component recorded a higher overall mean score than health functioning, and as it is shown in the chi-square there. And so it's an indication that kidney donation was psychologically satisfying to them, and it is consistent with other studies that had been done before. Another component that we looked at in the psychological components, we looked at how they were relating with the community and how they related with the recipient. The results indicated that being appreciated by the family members was rated as the highest. It is something that is satisfying to the donor, and the satisfaction with the social interactions within the community was also an important factor in the quality of life of this person. Looking at the quality of life and health functioning, donors who are more concerned about their life after they donate than they were before. So they were more concerned of what they eat and the lifestyle they had after kidney donation. Again, a number of respondents indicated that they were satisfied with the level of activities they are able to perform in the society, which was that they were able to interact back to the community and take up their social roles in the community after kidney donation. Looking at the BMI, the BMI had a strong, positive, significant relationship with health functioning as a component of quality of life. And therefore, people were more concerned on how they keep their weights and what they eat and their eating habits. And therefore, it recorded a positive, a significant relationship with health functioning, as it is indicated there. Looking at the relationship between...
Hi, Divina, if you can summarize in 2 minutes, please.
Okay. Okay, it's quite difficult to summarize in 10 minutes a whole presentation, but just to summarize a bit is we're looking at the socioeconomic factors and the psychological factors when you apply the Pearson correlation, is that the current, the income the patients have, the donors have, as a significant psychological relationship. There's a significant psychological relationship between a monthly income and being in employment with the quality of life of the donor. So having said this, all these, looking at the predictors of the quality of life, the psychological factors contributed to 12.5% to the quality of life, and health functioning 27.5%. And the marital status of the kidney donor had also a positive predictive relationship, although it was statistically insignificant. But current employment and the amount of money these people get had a positive, significant predictive relationship with the quality of life. So what were the conclusions of this study? The overall quality of life of kidney donors at Kenyatta National Hospital were high, and the socio-demographic and economic factors had played a significant contribution towards quality of life of kidney donors. And there was statistically significant positive predictive association between donors' employment status and quality of life. The recommendations that were drawn from this study is that we need to develop a risk assessment tool to be used for counseling the prospective donors to enhance quality of life, develop an education tool for them, and the transplant centers should provide forums where these donors can interact with each other, and also get forums how the materials can be shared, and a link to actually connect them to the other donors globally. Areas for further research. It was recommended that we have a more longitudinal quality of life study to be carried out to follow donors for a longer period of time to establish if there is any changes to their quality of life on the donors that can be associated with a kidney donation, and also develop a structured follow-up guideline and registry to enhance a living donor quality of life. Thank you very much for listening to me.
Thank you very much, Divina. Great presentation there. Continue to write your questions in the QA session. And thank you so much, because I can see you're prompting more people to join. Now we move on to the second presenter. It is important that you put your presentation in full screen so that we can all share, even as we listen to what you're saying. Our next presenter is going to be Nancy Wangombe. She is a transplant coordinator at Kenyatta National Hospital. She holds a master's in donation of organs, tissues, and cells for transplantation, University of Barcelona, Spain. And she's going to discuss the overview of kidney transplant services at KNH. Thank you so much, Nancy, for taking this. Kindly proceed.
Good afternoon, everyone. I hope I'm audible, and please tell me whether the slides are moving. Just let me move. Are they moving?
Yes, you're audible and they're moving. Proceed.
Okay, thank you. I thank the organizing research department of Kenyatta National Hospital for giving me this chance to speak about transplantation. And transplantation is the next big thing. Much of the things that happen around that our patients get end-stage organ failure, whether it's a heart, whether it's a kidney, the ultimate treatment, and why maybe when you read the West have higher quality of life than this, because of the facilities that like this that are available. This is my topic, transplantation program at the Kenyatta National Hospital. I'll be very brief. So that you're on the same page, let's get some definitions correct. Like transplantation is the act of transferring cells, tissues, or organs from one site to another. That is broadly transplantation. It can be of cells, tissues, or organs. But if we are talking about organ transplant, so that we don't interchange, is an organ transplant is a surgical operation where a failing or damaged organ in the human body is removed and replaced with a new one. These are the activities happening. This map is from the World Health Organization of 2022. And much of the green, the more darker the green, this is where they have per million population of above 100, or where we have a lot of transplant. That is from the United States of America, Canada, western part of Europe and Australia. And the more pale or the more gray, it means there's no data available. But for us in Kenya we are here, you can see we have a yellow color. That means we have some form of activity. It is followed, the most active countries are followed slightly by the less green, which is some part of Brazil and another part of Canada. When you're talking about transplantation, we are talking about the organs. And we say that one organ donor can help 8 patients. If you count all these, they add up to 8. You can give a heart, 2 kidneys, liver can also be split. Sometimes if you're giving children, spleen, lungs, and pancreas. Of the tissues, you can either give the eyes, cornea, musculoskeletal, bones, or heart valves. Of the cells, we are talking about the stem cells. History of transplantation is good always to look back where everything came from. And they say that the first mention of transplant was in 1550 years BC, where they mentioned skin graft as treatment of burns. And then there is verifiable documented data where a Swiss surgeon, Jacques, did a transplant in 1869. The most successful transplant we say where the barrier for rejection or where the one kidney was able to be accepted by the body was in 1954 by Joseph Murray in Boston, where identical twins shared organs, one twin donated to the other one. But in 1959 also they did where the individuals were not genetically identical. So we say that for success of transplant is marked by the 1954 and the 1959 episodes. In Kenya, the first transplant was performed in 1978 by Professor Nelson Awori at the Nairobi Hospital. And interestingly, it was a deceased donor transplant where a Caucasian person was admitted in the same hospital. Wherever he had come from, he had consented to his organs being used to help another person. And in that hospital, there was a girl who was airflown by AMREF flying doctors from some northern part, I think in Turkana, somewhere, where they had removed a horseshoe kidney thinking it was a malignant kidney. Then they realized this girl all along had one organ. So that the Caucasian person had consented to donation. They got the kidney from that Caucasian person, gave to the girl, and she lived. So that was our first transplant ever. Cornea transplantation started in Kenya some 30 years ago. Those are the 2 transplants available now. But as much as we will see that bone marrow has also started in the country. In Kenya, in Kenyatta National Hospital, sorry, it's not Kenya, it started in 1984 with the service being regular. But by late 90s, the program slowed down as India marketed its services and patients opted to going to India for surgery. Then when now the program slowed down, the hospital revamped the transplant program by forming a program that we normally call Interlife. I'll mention about it briefly. In 2010, and much of the data that we mentioned, we talk about the 2010 Interlife program as much as we started transplant in 1984. And here is the partnership. It was a partnership between Novartis Pharma, Kenyatta National Hospital, and the Novartis Pharma joined us with a sister center in Barcelona, Spain, where they had held our surgeons to the latest techniques, and we have since gotten better surgical outcome. And these were the objectives of the Interlife program, was to develop KNH to perform renal transplant, to develop KNH to be a center of excellence, anchor Kenya as a preferred choice of transplant surgery in the region, and to encourage patients to seek local surgery. And these were the objectives. The objectives were capacity building, improving outcome, improving access, and program awareness, where we have always engaged ourselves in publicity, media campaign, international symposium, celebrations like the World Transplant Kidney Day, and outreaches. From then on, when we started now increasing the numbers, we had now space. We had several problems, like infrastructural problems. And that is when the government sponsored the expansion. For the people who know Kenyatta National Hospital, this is the old renal unit. They pulled it and expanded the transplant center. And we are calling it the Center for Kidney Diseases and Organ Transplantation. It was inaugurated in 2022 by the then president. This is when they opened the unit, and also a HLA lab. We normally call it a matching lab, where a donor and the recipient can be genetically matched to see whether the outcomes of the transplant will be positive. So the unit opened in 2020. It has a 17-bed dedicated transplant unit, has 2 dedicated transplant theaters, has a pre and post-transplant clinic, and has capacity to perform daily transplant. It has an established renal and HLA laboratory. So this is the continuum of care that is provided at the center. We normally have pre-transplant workup, where we prepare our own patients for in-house. Our in-house patients, we mean the patients who are dialyzing in KNH. They're prepared here, or we get referrals, because there are only 2 public hospitals so far that are giving this service. And so we receive any referral from anywhere. In fact, even we have some people on the waiting list from outside the country. We screen approximately 170 patients per year for transplantability, and the process normally takes around 6 weeks or so. And our clinic normally runs every Tuesday between 9 a.m. and 1 p.m. Once we work up the patient, they are taken to a multidisciplinary team meeting where they are discussed and their eligibility confirmed. Then they are given a date for transplant. And now on the transplant surgery, it takes around 15 days for the recipient, where we admit them 5 days to just straighten up anything that would not be optimum, to optimize them. And then 8 days post-transplant, they go home on day 8. And their donors, they stay in the hospital for 3 days. And so far, we have transplanted 270 patients since 2010. Remember, I mentioned the importance of 2010. However, we had other numbers of patients. In fact, even most of our patients who are following up, we are following them up in the post-transplant clinic. They are like 25, 26, 27 years old post-transplant, and they were transplanted during the older program. For the post-transplant follow-up, we have more patients who are being followed up here from in-house, the ones that we have transplanted, and referrals from outside the country and private. Why? Our medication is always like a third of of the much it costs outside there, or sometimes the patients have transplanted outside the country, they want to be followed up here. So we are following up around 600 patients. These are our transplant services available. This is one of the patients that we transplanted in 2021. We are now on the process of opening a cornea transplant and banking center. We have a renal lab. For the people who would appreciate that a renal lab is necessary for you to start up any transplant program. It takes care of specific transplant tests and also just the usual kidney test. We have the histocompatibility and immunogenetics HLA laboratory. And unless it has started, we were the only one that were having it locally. Before this, we would send the test to India or South Africa. But now it has really brought the cost of testing considerably down. Number 2, turnaround time. The turnaround time for the test, when we used to send them to South Africa, used to be 21 working days. But here it's within 24 hours, you're able to get your results. We also do some biopsies, let's say for the grafted ultrasound or for the native kidneys, they're also available here. And this is one of the surgeries in our theaters, the transplant surgery.
2 more minutes, please.
Okay, I'm about to finish also. So what is the future of Center for Kidney Disease and Organ Transplant? The hospital is on the process. I've shown you that the room is now getting renovated for cornea transplantation and tissue and cornea banking, where we'll be able to do cornea transplant surgery, liver transplantation. And remember, the 3 transplants that we are onboarding immediately are living related. We are not depending on deceased donor program. So once the cornea transplant has started, the liver team is also in high gear to start what we call split liver. Split liver is where they can subdivide this liver and they share between the donor and the recipient. And it has been shown that once the liver is transplanted, it can be able to continue growing and go back to the other side, the size that it was. Bone marrow transplant, it has already started in a hospital in Nairobi, but as we are about to start, whether it can be across or it will be autologous transplantation. So this is some of our activities here. Last year, we had the first laparoscopic kidney transplant in a public hospital, where we say that you don't have to do a very large incision to get a kidney donated. They can do it, they can collect it laparoscopically, and we are able to do it now here. This is one of the transplant surgeries from the beginning. We have a lot of data that we have decided now to go to e-health and digitize all our records because they are important. You hear even we have traditionally the medical records are archived after 10 years, but as we need hours for research to continue growing, some of our patients are still living, like the one I was telling you about, 26 years old post-transplant. These are some of the clinics and review rooms for the transplant unit, the coordination office. At the beginning, when we started the first year, 2010, there was published a poster that won an award in Europe. By that time, we had only transplanted 23 transplants, but it really featured in Europe for a conference. And these are some of the activities we've been having. We normally have outreach where we ask patients to come and we screen them for eligibility of transplantation. We sometimes go outside, like this time we had gone to Isiolo, Meru, and Laikipia for screening for kidney disease. So what is the future of transplantation in Kenya? We have this one, this notice that went out that MPs are pushing new law to allow harvesting of body organs. And we have a body that is now established called Kenya Blood Transfusion and Transplant Service, where you can now be able not to rely on living donors, because living donors is a disadvantage. You can imagine some diseases around in family. If I'm hypertensive, even my relatives are hypertensive. So we are hoping to rely on deceased organ donor, and this is one of our photographs of our first group of patients, the cohort of 2010. There's donors and the recipients and the doctors. This was a team from Spain by that time, and the clinical people. And we always value, because this is where we came from. And I thank you for listening.
Wow, thank you so much, Nancy. Indeed, we like where we are heading, because at some point or another, we will need some form of donation. Next, we are going to have Joseph Nduati. Joseph Nduati, as I introduce you, you can share your screen. So Joseph Nduati holds a master's in nephrology nursing. He has a higher diploma in critical care nursing, and he has a higher diploma in epidemiology. And I know he's taking a PhD somewhere. And Nduati, if you can go full screen, it will be great first. Go full screen. Use the hourglass. Thank you so much. That's full screen. You have 10 minutes starting now. Thank you so much. And thank you, participants. You are tagging others to come on. Now we are 800 plus. If you can push them to 1,000, 1,100, 1,200, it would be great as we start 2025. Thank you.
Good morning, good afternoon, good evening from every part of the world.
Hi, we can hear you. Go on.
Unfortunately, my slides are not moving. I think when I'm in full screen share, I don't know why. A minute, please. Share. Okay. You can see my slides?
Yes, we can, but not in full screen. Go on.
This is about a study that we did in the year 2020-2021. It was about determinants of kidney transplantation uptake among chronic kidney disease patients on hemodialysis. Selected national referral hospitals in Kenya. It was a multi-center research that I did in Kenyatta National Hospital, Lindo unit, as well as MTRH, Lindo unit. And as per our background, as we all know that CKD is a major public health concern with a global prevalence of about 13.4%, whereas of that in Africa stood at 10.1%. In KNH, 40% of inpatients, they have CKD, and 1 in every 7 end-stage kidney disease patient will require renal replacement therapy for survival, be it hemodialysis, CRRT. And as we know, kidney transplantation offers greater benefits as compared to hemodialysis. Despite this fact, the uptake is low, especially in Kenya. By the time of the study, we had 4,500 patients on maintenance hemodialysis in Kenya, that is both in private and public institutions, against 466 kidney transplant since 2006. The problem that I found that made me to do this research, it's all about the CKD. We know it has a global disease burden of about 11 to 13%. In Africa, retro is known because our data is not up to date. As we know, it is the best treatment of choice. In terms of benefits, the uptake is low. Global uptake of kidney transplant starts at about 10%. In USA, 29.6%. In India, about 3.4% per year. In Sudan, they have performed more transplants than Kenya, because in the year 2011 to 2015 alone, they had about 150 kidney transplants. They usually have visiting doctors from developed countries. And to justify the study, we know the quality of life of CKD patients solely depend on treatment modalities chosen. Transplant offers the best modality, and I selected KNH and MTRH because they are the only public health facilities that conduct kidney transplantation, and they have the largest population of CKD patients. Broadly, the objective was to establish a relationship between determinants of kidney transplantation uptake among CKD patients on hemodialysis in MTRH as well as KNH, specifically to know what's the relationship between social-demographic factors and kidney transplantation uptake, what patient perceived factors influence the uptake of kidney transplantation, as well as the perceived health system factors that influence the choice of kidney transplantation. Conceptual framework, I had several dependent variables, socio-demographic factors, patient-related factors, as well as health system factors as perceived by the patient. And the dependent variables or the outcome were either the intention to undergo kidney transplantation or lack of that intention to undergo kidney transplantation. It was a cross-sectional correlational study design. As I have said, it was in KNH, MTRH renal unit. We targeted population of 192. By that time, MTRH had 40 patients under hemodialysis. KNH, we had about 152. And a sample size of 128 was reached that. We had inclusion and exclusion criteria. We included those who were 18 years and above who consented and were undergoing maintenance hemodialysis. We collected data using self-structured administered questionnaire as well as interviewer administered questionnaire. We did pre-testing to establish validity and reliability, which was done at KNH. The process of data collection, we obtained consent from relevant authorities. We engaged respective dialysis units during dialysis sessions. That is where we got our participants. Data management, we used SPSS version 25. We used also descriptive statistics as well as inferential statistics, especially chi-square and Fisher-Exact tests to correlate with the variables. Also, binary logistic regression was used to analyze the predictor for kidney transplantation. In terms of ethical considerations, we were able to sought permission from relevant authorities. Result, under social demographic variables or characteristics, majority were men at 50.8% of my respondents, and they were aged more than 50 years, that is at 9.1%. Majority, 39.8%, had tertiary education, they had gone beyond secondary school education. Also, majority were married at 53.1%. Christians were at 78.9%. In terms of occupation, majority 60.5% were unemployed. Most of them had lost job due to the nature of their illness. Family income, majority had less than 100,000 per year. 96.9%, the dialysis was being paid by NHIF, previously NHIF, currently we have SHIF. In terms of patient-related factors, those who had dialyzed between 2 to 5 years were the majority at 71%. Those who have ever heard of kidney transplant were a majority, 99.2%. 74.2% had already discussed kidney transplant with their service provider. And there was a very good knowledge on kidney transplantation among the participants, 92.2%. Those who have been referred for kidney transplant evaluation stood at 54.7%, which is quite low compared to the number of patients we have with end-stage kidney disease. Those who have ever planned for transplant stood at 50.8%, but the one who had started the process were 39.1%, that is among the 128 participants. In terms of donor preference, majority 78% preferred a living donor, although we do not yet have non-living donor programs in Kenya. It is in the almost being established. Only 22% preferred that. In terms of comorbidity, those who had comorbidities stood at 7.5%, and the majority had hypertension, followed by hypertension and diabetes, that is concurrently, then diabetes at 11.6%. We had others with hepatitis B and the rest. There was a question about the benefits of kidney transplant, and the majority believed it will improve the quality of life, that is 60.2%. But interestingly, that 5.2% did not know any benefit of kidney transplant. Then we tried to assess the kidney transplant uptake. We assumed, or we took a certain population of the patient who had already started the process, who had stood at 99%, whereas 61% had not started the process of kidney transplantation. And in terms of our results, in terms of objective number 1, where we wanted to know, is there any relationship between demographic variables and the uptake or the choice of kidney transplantation? A number were statistically significant to include age, where we found that those who are more than 50 years of age were less likely to undergo kidney transplantation than the younger counterpart. Christians were more likely to undergo the same than Muslims. Those who were employed were more likely to undergo kidney transplant. Most of the variables were not statistically significant. In terms of demographic characteristics, where we have found that age, religion, and occupation were associated with the kidney transplantation. I have mentioned that. And to find out whether we have any patient-related factors that influence their choice of kidney transplant, where they opted hemodialysis more than kidney transplant, we found that few variables were statistically significant. I only mentioned about these variables. We had knowledge about kidney transplant. Who have ever heard about it were more likely to undergo kidney transplant. Those who have ever discussed about the kidney transplant with their healthcare providers, those who have been referred for evaluation, as well as those who have ever heard about kidney transplant. Those who had comorbidities were less likely also to undergo kidney transplantation because they believe they cannot withstand this nature of surgery. There are some patients who felt uncomfortable asking for a kidney from a donor, but despite that fact, that was not an impediment to transplant. If they could get somebody to ask for them, they would undergo kidney transplant. In terms of age, those who perceived to be too old for kidney transplant, they totally disagreed, so majority would go for kidney transplant. In terms of association between health system factors and the transplant, this is the hospital and the care providers. Those perceive that a certain hospital do not have enough qualified persons to undergo or to do kidney transplant, majority disagreed to be one of the barriers, whereas hospital equipment really influenced that if they feel the hospital is not really equipped, they will not go for kidney transplant in that particular hospital. The importance of counseling patients, those who had received counseling and also referrals, they are more likely to undergo kidney transplant. Our attitude as healthcare workers, the health providers that had positive attitude really stimulated some patients to think about kidney transplantation uptake. Then we had predictors. We did a binary logistic regression to find out what are the predictors of kidney transplantation at this study, and we found that age was one of them, fear of surgical process, as those who feared the process would not likely to go for kidney transplantation. Those who had concerns about their poor health and they had comorbidities, they were also shy to undergo kidney transplantation. Availability of donor was another impediment. They strongly agreed, and in our binary logistic regression found that it is one of the predictors that prevented this patient to consider kidney transplantation. In conclusion, it's only less than 1/3 of the respondents were willing to undergo kidney transplantation. And this is a summary of the factors that influenced this decision. Patient age, where we have found more than 50 years of age, were reluctant to undergo kidney transplantation. The region where Muslims were less likely to undergo transplantation. Those who are employed in terms of occupation would favor transplantation. Those who had information about kidney transplant, the same. But those with comorbidities, especially hypertension and diabetes, were less likely to undergo kidney transplantation. They would prefer to remain in hemodialysis. In addition, we had fear of surgical procedure and lack of donors, a significant association with kidney transplantation uptake. Also, hospital capacity in terms of equipment, as well as staff qualification and skills as perceived by the patient, was also an influence in choice of kidney transplantation. As I have said, the predictors were as follows: age, occupation, donor availability, concern of poor health, as well as comorbidities and fear of surgical process. In our recommendations, we recommended that efficient educational programs are required to increase knowledge on the benefit of kidney transplantation, because we have found that Pardon? Those are the recommendations that we made, all about increasing sensitization in terms of funding of transplant from the government, as well as. Okay, my time is up, but I'll be putting up, in case you want to the full journal, it is published. You can access through the given link. Thank you. Thank you. I'm done.
We can't hear anything, Christine. Dr. Christine, please.
Hello, Dr. Ngaruya and everyone. Are you able to hear me? Sorry, I dropped off.
Yes, now we can hear you now.
I'm so sorry. I'm so sorry. You're muted. You're muted. You're muted.
So I hope you can hear me. You can see the screen.
Yes, you can see the screen.
Yes, Dr. Ngaruya, we can see, and I'm sorry about dropping off. Kindly proceed.
Good afternoon, everyone. As you have heard, my name is Dr. Grace Wanjiku Ngaruya from the University of Nairobi. I'm going to talk about the role of the nephrology nurse in resource-restrained country, a Kenyan experience. As far as kidney replacement is concerned, I'm going to talk about peritoneal dialysis, which has hardly been mentioned as a kidney replacement therapy. Peritoneal dialysis is the use of the intra-abdominal capillary-rich peritoneal membrane as a dialyzer, and this is what we call an intracorporeal circuit, whereby the blood is not removed from the body of the patient. It is dialyzed while it is still within the body. Peritoneal dialysis is a good type of dialytic kidney replacement therapy that helps to lower the demand for hemodialysis. You know very well of late, we have had issues with the machines, even across the country, including our richest leading hospital in the country. We had the challenges with the machines. But here we are using the patient's own peritoneal membrane as a dialyzer. Peritoneal dialysis is better than hemodialysis because it uses a simpler method that leads to more gradual improvement in the body. There is no need for a water treatment plant, and it can be self-administered at home with the adequate training. You can see that this is the peritoneal membrane that covers all the abdominal organs. When you stretch it, it is 1 to 2 meters square. We have the parietal peritoneal membrane and the parietal layer and the visceral layer. In between that layer is a peritoneal cavity that under normal circumstances has serous fluid over but we can still dialysate of up to 2 to 3 liters. I hope my internet is okay. You'll see that the catheter is a soft catheter, is a permanent catheter, which is connected to an adapter. This one we call titanium adapter from Baxter, that is can be permanent in the sense that it can be autoclaved in between patients, especially when the patient goes on transplant or if the patient has opened up. Now, the patients on peritoneal dialysis, they actually have preserved kidney residual function. And these are patients that would have transplant outcome. You very well know that most of the patients on hemodialysis send blood into the machine like 400 mils per minute. And so all the blood is diverted from the kidney, and that's why the kidneys continue drying up with the hemodialysis. But with the peritoneal dialysis, because you are dialyzing the patient's blood, while it is still in the body, we have more sustained residual kidney function, and in fact, even the vessels are preserved, and therefore the good outcome of transplant. Now, if you look as far as our background is concerned, whereas PD would be the preferred first mode of kidney replacement therapy, it has been scarcely used in Kenya. There are only 6 patients currently on maintenance PD. A 6-year-old child whom I started PD when he was 2 years. Now he's already going to school on PD. On PD when he was 12 years. Now he's 19.
Hello, Dr. Garui, are you there? Is everyone able to hear me?
Yes, I can hear you.
Yes, I can hear you
Are
loud
you-
and clear.
Are you
Yes, we can
hearing
hear.
Dr. Garui?
She's dropping off. I think there is poor network where she is.
Yeah, I've just done a text to her to alert her about her network. Meanwhile, let us respond to 3 questions that have been posed. BMI, kindly comment on BMI after kidney donation. It was not clear to the audience. And then number 2, can a patient with cerebral palsy be transplanted with kidney? That is question number 2. Question number 3 is, what is the uptake of organ transplant in KNH compared to previous preference to going to India for the same? And how is the affordability? The other issue is about CPDs. If you do not get a code for your CPDs, kindly write to the same email that we communicated through so that you can get your code. Let's take the questions as we see if Dr. Garuya will come on. Thank you.
I think I can go first. About the uptake of kidney transplant in KNH, we now have even a queue of patients waiting. We are now having patients believe in the program here. And so far, I mentioned we have already transplanted 270 patients, but the impediment for kidney transplant has been post-transplant medication. Patients were not afford. It was costing around 30 to 40,000 a month. So that is what had slowed down progress.
Oh,
But
22.
now, the SHA has started covering the medication post-transplant, and they are covering up to 16,500 a month for the post-transplant patient. And since that time, we have seen an upsurge. Like now, we have a waiting list of around 20 patients. So I think that issue of affordability now, we have already gone around it, and we'll be able to see much. So if you are a member of SHA, both donor and recipient, they will be given some money for preparation, surgery, and post-transplant medication. I'm hoping I've answered that question.
I believe you have. Without giving data, I guess data we'll give later. Divina, would you like to comment on BMI after kidney donation? Grace Ngaruya, kindly mute as you prepare to come on. Meanwhile, we are responding to questions.
Okay, thank you so much. And sorry that had been thrown out.
Sorry about that. Divina, are you there? Okay, kindly Wangombe reach out to her for me. Can a patient with a cerebral palsy be transplanted with the kidney? If you can respond to that, please.
You can hear me now.
Yes, Divina, we can.
Yes, I was saying from the research, we had, the results showed that there was a very strong positive relationship between the BMI and the quality of life in the health functioning domain of quality of life. What we do is that part of the education we give to the donor is that the donor, as even before the donation, they need a healthy BMI. And after donation, we advise that the donors maintain a healthy weight, maintain a BMI within normal, because we all know that lifestyle diseases that come around that also they cause kidney disease actually come from the a normal weight is quite important in that aspect. People who have high BMI, they are likely to be, obese people are likely to get to hypertension, and they are likely to complicate to kidney disease. So we advise our donors to maintain a healthy body weight after kidney donation.
Thank you, Divina. I think Ngaruya, Dr. Ngaruya Wanjiku, you can continue. Are you able to share your screen? Or are you able to hear me to begin with?
Yes, I can hear you. So let me share again.
If you can take 4 minutes and summarize, and as you summarize, kindly talk about the indications for PD, because that's one of the questions that is pending.
So can you see my screen now?
Yes, we can, and we can hear you.
So I was just trying to say that around that 6 children are on acute PD using improvised fluids at the Kenyatta National Hospital every month. And this has saved a lot of lives. And we have a few hospitals in Nairobi, Pisha and Gertrude that are, and even Nairobi Hospital that are doing few cases. The reason why there's improvisation is because the conventional fluids are not available, in the sense that the utilization was low and most of the companies pulled out. About 10,000 people are suffering from kidney failure, and the required dialysis can access the services. In Africa, you can see the dialytic kidney replacement therapy of choice is hemodialysis, and therefore there is underutilization of PD in Africa. So mainly the problem is the costs, low patient education, lack of expertise, and maybe the surgeons that are not available. At times we have no even catheters, so most of the surgeons would not allow us to improvise catheters. So this is just to show the uptake of PD worldwide. In Africa, there is really low utilization, while other countries around the world, the ones you can see in deep green, are using peritoneal dialysis. So here is what we need for successful peritoneal dialysis. We need a multidisciplinary centers focus, where we have to have support from pharmacists, occupational therapists, and doctors, and working as a team. And for us to have a very successful PD program, we need nurses that are really dedicated. And this is a photo of where we went in South Africa. And we had 3 nurses from Kenya with the 2 doctors, where we were taught how to do improvisation of peritoneal dialysis by an organization called Saving Young Lives. You can see Kiriba is one of the nurses from Kenyatta National Hospital who came and started improvisation in the pediatric renal units. Please, we need to recognize this nurse because she is the one who even started improvisation, the first case for adults at the Kenyatta National Hospital. And this has actually subsequently saved a lot of lives until pharmacy took it up. The nurses were mixing up these fluids in the ward. So this is the workshop that we had. And I don't know whether I have time, but I want to say that we had a case where I was called in one of the hospitals. They did not have a catheter. And from this training, I was able to fix a central line as a peritoneal dialysis catheter together with an MO. There was no pediatric nephrologist in the hospital, and there was nowhere that we could actually transfer this child because it was during Christmas. So the hospitals, even Kenyatta was full, Gertrude was full. And so I had to use a central line from this training. We fixed the central line in the peritoneal cavity with the MO, with no nephrologist, no surgeon. And you can see that you will see from this case that dialysis was started using the improvised catheter and the UECs came down. So I want to say that the nurses can be able. I was talking of the role of the nephrology nurse in ensuring that we use our knowledge to save lives. So I am just discussing in this case study how I directed the MO, and we were able to use the guide wire. Maybe you can read these notes because I have only 4 minutes on how we managed to insert the catheter, improvised catheter, and then we were able to use the catheter, and eventually you will see how the UECs came down. We had also another case whereby I managed the patient, and you can see in case 1, the urea came down with the improvised catheter, and also the urine output improved. And also the potassium levels stabilized in this patient. Though the patient eventually died of complications of jaundice because of the septicemia, because of late referral. This is whereby we are managing the patient in the acute setting. And I can say that in South Africa, we were trained to insert the catheter using the pig's meat. And in conclusion, we can say that with the teamwork, we can be able to encourage patients to go on a peritoneal dialysis and use the knowledge we have in the multidisciplinary. Sorry for my network problem. Sorry for my network problem, but I hope you can hear me. It is hoped that teamwork will provide foundation across African countries to share lessons for the need for the development and implementation of PD first and favored policies. A multidisciplinary approach supported by various subspecialties is required to maximize PD outcome. So I want to go ahead and answer the questions as far as indications. So actually in most countries, PD is indicated for any patient that is willing to be started on PD. And what is being encouraged is PD favored policies, PD first policy. In the sense that if we have a transplant program, we would like to start all patients on PD. We can even start a pregnant patient on peritoneal dialysis. So indications are any patients who are high creatinine, any patient in fluid overload, either with acute or chronic acute kidney injury or end-stage kidney disease patients, they can be started on PD, whether a child, and also in children, the outcome of PD is even much better. So thank you very much. In the interest of time, you can read my presentation later on. I'll be able to share. Thank you.
Thank you so much, Dr. Ngaruya Wanjiko. Your presentation is surely clear and we have learned a lot. I think all the questions have been responded to, and I thank you for the clarity. Sorry about the network. Kindly, we look forward to having another engagement next week. Be on the lookout for our communication. I take this opportunity to appreciate each one of you, participants, nurses, doctors, and nephrologists that are on board. Thank you, Divina Kemunto Nyarera. Thank you, Nancy Wangombe. Thank you, Joseph Nduati. Thank you, Dr. Grace Wanjiko Ngaruya. And let us keep it nursing. Let us keep it healthy kidney. Let us prevent, let us treat, and let us help our patient to recover better. Next week, we will be covering reproductive health. We will have several speakers next week, and therefore spread the word. Having said so, may I take this opportunity again to wish you a happy 2025. Mungu awabariki sana. God bless you. Thank you very much.
Thank you, everyone.
Thank you too. Thank you too.
Thanks. Okay, bye.